Hi, my name is Emma, and I will be performing my health assessment lab practical today here this afternoon. I will first begin by closing the curtains in the patient's room to ensure privacy. I will then perform proper hand hygiene by washing my hands for a minimum of 30 seconds and drying thoroughly. I will then put on gloves to protect both me and my patient. I will now introduce myself and then begin with a few questions. Hi, my name is Emma, and I will be your nurse today. Could you please tell me your name?
My name is Zachary.
Hi, Zachary. It's nice to meet you. Could you please tell me where you are today?
I'm at home in my apartment.
And what month of the year is it?
It's July.
The patient's responses indicate that he is alert and oriented times 3. I'm now going to ask him to perform a simple motor command. Zachary, could you please take both of my hands and squeeze them? Perfect. The patient's eyes opened when I walked into the room. He had appropriate verbal responses and was able to follow a simple motor command, and therefore he receives a Glasgow Coma scale of 15. I will now move on to a few questions. Zachary, do you have any allergies?
No.
Do you have any past medical history you'd like to make me aware of?
No.
Do you take any medications, including over-the-counter medications or herbal supplements?
No, I don't.
Do you smoke?
No.
Do you consume alcohol?
No.
And do you use any non-prescription drugs?
No.
Could you please tell me about your typical exercise routine?
I do weight training 4 to 5 times a week.
Great. And do you mind elaborating on your perception of your health?
I think I'm in pretty good health right now.
Awesome. I am going to begin with my head-to-toe assessment. I'm going to be inspecting, auscultating, percussing, and palpating different regions of your body. I will explain what I'm doing as I go along. Do you have any questions?
Nope.
Great. With your permission, I will begin.
That sounds good.
I'm going to begin with an assessment of the eyes. I'm going to be looking to see that the conjunctiva is pink and moist, that the sclera is white, and the pupils are equal and round. I will then be using my pen light and shining the pen light into his left eye. I should see his left eye constrict and his right eye concentrically constrict. I will do this one at a time. I will now move on to the accommodation test. Zachary, could you please look at the photo on the wall across the room? I'm going to place my finger in front of your nose, and I'd like you to stay focused on that photo. Now I'd like you to look at my finger. When the patient focuses on my finger, I should see constriction of the pupils and conversion of the pupils. They should both equally be looking at my finger. Next, I'm going to do a visual assessment of the mouth. Could you please open your mouth and say ah? I'm going to use my pen light to observe that the soft palate is raised, that the oral mucosa is pink and moist, and that the uvula is in the midline. Moving on to the neck, I'm going to visually assess inspect that the trachea is in the midline, and then I'm going to use my fingers and feel for the carotid pulse one at a time. This patient's carotid pulse receives a grading score of 2+. I will now be assessing the cranial nerve 11. Zachary, could you please raise or shrug your shoulders up and down and move your head side to side? I'm now going to apply slight resistance and ask him to do the same thing. Great. I'm now going to move on to the respiratory assessment. I'm going to begin by inspecting the skin and observing for any cyanosis. I'm going to watch the chest rise and fall as a measurement of the respiratory rate. I'm also going to, as he's breathing, I'm going to be looking that the chest is rising equally and that they are not using any accessory muscles, because this might be a sign of respiratory distress. Zachary, could you please stand up? I'm now going to be assessing the AP transverse ratio by looking at the width of the AP measurement here, anterior posterior measurement, and then having him turn and looking at the transverse measurement. The AP should be 1 to 2 to the transverse, and this patient has a normal finding. If it were to be 2 to 2, this is an indication of a barochest, which is common in COPD patients. I'm now going to begin with palpation. I'm going to have the patient stand with their back towards me. Could you please turn around? I'm going to begin with placing my hands around right around where the elbow is at T9, T10, and then having the patient take a deep breath. My hand should expand. Could you take a deeper breath? My hand should expand equally. If they were not unequal, then it would show that there's a deficit in one of the lungs. I am now going to be performing tactile fremitus. Could you please repeat the numbers 99?
99, 99, 99, 99, 99, 99.
You should feel equal vibration in both hands. It's preferred to use the ulnar side of your hand while doing this assessment, and you can be comparing the vibrations from the left to the right. If the vibrations were to be increased, this may be a sign of consolidation or fluid in the lungs. If the vibrations were to be decreased, it might be a sign of obstruction. When doing this assessment and other assessments of the respiratory system and cardiac system, it is preferred that the patient not have any clothing on their skin so that you can visually see and feel without having clothing between you and the patient. I am now going to move on to percussing the lung fields. I'm again going to have the patient with their back towards me, and using my fingers, I'm going to percuss along the scapula. You don't want to be on the bone. And I expect to hear resonance. This is a normal finding. Another assessment that has been used in the past but is not recommended for current practice is diaphragmatic excursion. This is sometimes used to measure the expansion of the diaphragm, but is no longer recommended for use today. I will now auscultate the lungs, and I'm going to begin with the front side of the patient. There are 3 different lung sounds to hear. You have the bronchial sounds, which are around the trachea. You have the bronchiovesicular sounds, which are between the bronchial sounds and the vesicular sounds down here. When I'm listening to the bronchial sounds, I expect to hear a longer expiration than inspiration. Bronchiovesicular sounds, I expect to hear equal expiration and inspiration. And the vesicular sounds, I expect a longer inspiration duration of the sound. I will begin. For the sake of time, I'm just going to demonstrate the movements I would continue with. We go 1, 2, down, across, for a total of 6 points of auscultation on the bronchial sounds. I'm then going to be using my stethoscope to listen to bronchiovesicular sounds. You would want to be sure to move all along the chest. The vesicular sounds are going to be heard further down in the lung field. Again, you would want to be doing this assessment underneath the patient's clothes. And I will also be doing the bronchiovesicular and the vesicular. I'll be auscultating the bronchiovesicular and the vesicular sounds on the posterior side of the patient. Again, here you're going to be avoiding the scapula. You don't want to be listening to the lung over the bones. And up here is where you're going to be hearing the bronchiovesicular. Be sure to reach up high because the lungs sit high on the back. And going down, you want to make sure you get all of the different lung regions. Next, I'm going to be performing the egonophony test. I'm going to have the patient, I'm going to do this again. I'm going to have the patient turn their back towards me again. And could you please say E every time you feel my stethoscope move on your back?
E. 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 E.
I would continue with this assessment all throughout the different lung regions. I heard a muffled E. This is a normal finding. If I were to hear an A sound, this would be an abnormal finding and may indicate consolidation. I'm now going to move on to the cardiac assessment. I'm going to inspect the jugular vein. So could you please sit down? I'm going to have the patient move their head. Move their head so that their jugular vein is being pressed outwards a little bit. So could you please push your head that way? I'm going to be observing for the pulsation of the jugular vein. And then I'm going to, as if the patient were lying down, could you lay back just a little bit? I'm going to take a ruler. This was a ruler, and this was a ruler. I'm going to place the ruler at the angle of Louis here, and then place this other ruler at the highest level of distension of the jugular vein. When this ruler and this ruler join, that measurement should be less than 2 to 3 centimeters. If it was greater than 2 to 3 centimeters, it would indicate jugular vein distension and would require me to assess the hepatojugular reflux test. But since this patient's finding was less than 2 to 3 centimeters, that is not necessary. I am then going to palpate the chest, and I'm going to be feeling for the apical pulse. If the apical pulse were to be laterally shifted, this would be a a lift or a heave. I'm also going to be palpating along the patient's chest with gloves and with the shirt off for any thrills. These would be a vibration type feel and would indicate a grade 4, 5, or 6 murmur. I'm now going to auscultate the heart. I'm going to begin on the right, on the second intercostal space, on the right sternal border, and listen to the aortic valve. I will then move over to the left sternal border at the second intercostal space to listen to the tricuspid valve, the pulmonic valve. I will then move down, and at the third to fourth intercostal space on the left sternal border, I will be listening to the tricuspid valve. Then, at the fourth to fifth intercostal space, at the left midclavicular line, I will be listening to the mitral valve. I will now use the bell of the stethoscope to listen to any bruits in the carotid artery. A normal finding would be the absence of any bruits. Now I'm going to have the patient lie down, and I'm going to inspect their abdomen. If they're on a bed, it would be a little easier. This patient's abdomen is flat, and the color of the abdomen reflects the expected color for his ethnicity. I'm now going to auscultate the abdomen. You do this before percussing or palpating to ensure you do not stimulate any bowel sounds that should not be there. I'm going to begin at the right lower quadrant at the ileocecal valve. This is where bowel sounds are most active. I'm going to auscultate each region. I'm going to speed this up for the sake of time, but you want to be sure to move around in each of the 4 quadrants to listen to all of the different areas of the bowels. A normal finding would be to hear between 5 and 30 bowel sounds per minute. Anything greater than that would be hyperactive, lower than that would be hypoactive, and if you could hear really loud sounds not using the stethoscope, that would be borigamous sounds. None of those would be normal findings. I am now going to palpate the abdomen for any tenderness. If a patient were to come in with a complaint of abdominal tenderness or pain, you'd want to avoid the region of the pain complaint and do that last to avoid putting the patient in excruciating pain, not being able to continue with the assessment. I will now percuss the abdomen. And the normal finding for the abdomen is tympany. I'm now going to move on to the assessment of the upper extremities. I'm going to look at the patient's skin. His skin is looks to be normal for his ethnicity. I am also going to inspect the skin for any bruising or any skin alterations. I'm going to check the capillary refill by depressing the nail bed and looking for the color of the return of color under 3 seconds. I'm also going to be looking at the nail bed and observing for clubbing. This patient does not have any clubbing. If clubbing were, if you did see clubbing, if it was present, it would indicate chronically low levels of oxygen. I'm also going to be using the ulnar side of my hand to assess the patient's skin temperature, which should be the same throughout the body. I am also going to feel for the texture of the skin to ensure that it's smooth and dry. I'm going to be taking the carotid, brachial, and radial pulse and grading them. This patient would receive a 2+ for each of these pulses. And then I'm going to ask the patient to stand up as I assess the range of motion. Could you please extend your arms and hyperextend and flex? Now, could you please abduct, adduct, and perform internal rotation and external rotation? Now, focusing on your elbows, I'd like you to flex, extend, supinate, and pronate. With the wrists, I'd like you to extend, flex, hyperextend, and then do radial deviation and ulnar deviation. Now, could you please squeeze both of my hands? The patient has demonstrated normal findings for range of motion and strength. I will now move on to the assessment of the lower extremities. Could you please sit down? I'm going to begin with an inspection of the skin to observe for any abnormalities or varicosities in the legs. Next, I'll palpate the skin for temperature and texture. I'm then going to ask the patient, before range of motion, I'm going to assess the capillary refill in the toes. So again, I'm going to depress the nail bed and observe the return of color under 3 seconds. I will take the pedal pulse and the post-tibial pulse, and then look for the extension of the knee and flexion of the knee. And then I'm also going to have the patient do dorsiflexion. Could you please put your foot up? And plantar flexion, placing your foot down. And then could you please demonstrate inversion and eversion? And then with your toes, could you please do show me flexion and extension? And could you do abduction? There you go. Not all patients are able to do abduction of the toes, but he is sort of able to. And adduction, bringing them back to the midline. Now, this completes the assessment of the lower extremities, and I'm now going to continue with some questions about genitourinary functioning. Zachary, could you please tell me about how often do you urinate during the day?
Probably about 5 times a day.
And could you please tell me the color or appearance of your urine?
Slightly yellow, generally clear.
Do you ever notice any odor about your urine?
No.
What the patient's responses indicate about his urinary function is normal. Urination is normal between 5 and 6 times a day, should be clear to yellow, and there should be no foul odor present. I am going to conclude the exam with a quick discussion about skin health. Zachary, now that it's summertime, I feel like it's a really good time to talk about skin health. Is that okay with you?
Definitely.
It's really important to apply sunscreen every time you go outside, even during the winter months and when it's cloudy outside. The sunscreen will help protect your skin from the harmful UV rays of the sun. It's important that your sunscreen is 30 SPF or greater and water resistant, and it's really crucial that you reapply throughout the day. When you get home, it's really important to do a skin assessment routinely. Make it part of what you do in your normal routine. When doing so, there's a good mnemonic to remember. The A, B, C, D, E, F of skin assessment. That is, you want to look for asymmetry, border irregularities, colors, the diameter of different moles, the elevation or evolution of moles, and if anything is looking funny. It's also really important to visit the dermatologist at least once a year. That concludes my head-to-toe assessment of you. Do you have any questions?
I do not.
Thank you. Before I leave the patient's room, I'm going to wash my hands again for a minimum of 30 seconds and dry them thoroughly. Thank you.